So my name's Robin Tate, not Michael Perdices, but Michael Perdices has asked me, he's kindly put his email address up there, and I think he's keen to respond to anybody if you have questions in the areas that he was giving presentations on. Thank you. So we're going to, we've saved up the good oil for the last session. I think challenging behaviours are, the bread and butter of rehabilitation, because they can really get in the way of the delivery of all sorts of other therapies: physiotherapy, speech therapy, occupational therapy, nursing care, and so forth. And I'm going to focus, I'm not going to be talking about non-pharmacological management. It's going to be non-pharmacological management, and I am going to focus on adults with traumatic brain injury. Now, Dr. Krishnamurthy yesterday said something that really resonated with me. He said the families can live with the cognitive disorders, but they can't live with the behavioural disorders. And I think we can all, relate to that. Let's just look at the prevalence of behaviour disorder after traumatic brain injury. Well, they're common, and they can have a very disruptive effect on rehabilitation service delivery and community integration. And in fact, when I was working clinically in a brain injury rehabilitation unit, I remember that we had a very wonderful occupational therapy aide, Susie. And she used to work with me on behaviour management of many patients. And then one day she said to me she was going to the stroke unit. And I said, oh goodness, why? Because I thought she was quite happy in her work. And she said, well, I wanted to go to the stroke unit because there you have the little old ladies who pat you on the hand and say, thank you for my therapy, dear. Whereas in the brain injury unit, what you have are patients who say, get lost, you bitch. And of course, the language was a bit stronger than that, but you get the idea. Now, these behaviour disorders, they range in type, severity and frequency of occurrence. And I've talked about the system in which I work in New South Wales, that multi-centre, statewide network system of rehabilitation services. And Sabaz and colleagues this year, in fact, have published data on a cohort of 507 clients with traumatic brain injury who are currently receiving services in our state. And 54% of those people exhibited challenging behaviours. Now, interestingly, the presence of challenging behaviours was associated with level of disability. And you're all familiar with the disability rating scale. Of course, it's got many more levels than what I'm showing here, and I've collapsed a few levels, but that's just to give you the message. And the message was that of the 148 people who had no or only mild disability, in 71% of that group, there were no challenging behaviours. And 29% of that group did have challenging behaviours. But when you look at the more severely disabled group, the subgroup, and we've got 193 of those, we see the opposite pattern. So 23% of those people, there was no challenging behaviours, but 77% challenging behaviours were present. So it is associated with the level of disability. But there is a very interesting caveat. And here you'll see that I don't have the extremely severe disability group. I've forgotten how many were in that group. But there, the percentages are very similar. And we see this actually in the dementia literature also. So that if you are at the end of the disability spectrum, really there's not the opportunity for you to be exhibiting challenging behaviours. Now, Cummins' work, of course, they've looked at frontal circuits, and we know that there's 5 of those, 3 of which are neurobehavioral. So what we're concerned with here are the lateral orbital frontal area and the anterior cingulate cortex here that in the medial area has got lots of connections there with the medial striatal nucleus, accumbens, and that region mediates motivated behaviour. So what are we looking at? We can kind of, if we're thinking about the types of behaviour disorders, we can look at 2 broad groupings here. What we might call the excesses in behaviour. These are people who are poorly regulated. They don't have very good behavioural controls. So in clinical terms, they appear impulsive, they may have emotional lability, they may be overfamiliar, tactless, there may be sexual disinhibition, aggression, irritability, poor frustration tolerance, socially inappropriate catastrophic reaction. And you can see even within that grouping, there's a very heterogeneous range. And to my knowledge, people have not really looked in detail at subtypes of the disorders of control, and I think that would be a wonderful research project to do. And we see exactly the same thing with what we might call the deficiencies in behaviour, disorders of drive. And these will be related to the anterior cingulate cortex. We have behaviours such as apathy, abulia, lethargy, blunted affect, slowness, loss of initiative, aspontaneity, adynamia, inertia, poor motivation, social withdrawal and inflexibility. And again, we can see a very heterogeneous group of behaviours there. Now, in that prevalence study of Sabaz and colleagues, we can look a bit more fine-grained at the types of challenging behaviours. And I've done that by looking at the overt behaviour scale that Kelly and my colleagues in Australia developed. Now, for those of you who are familiar with this area, you will see that the first 4 items indeed come from the overt aggression scale that Alderman adapted from Udofsky. And we're going to talk a bit more about the overt aggression scale. But for this purpose, this overt behaviour scale is quite useful because it adds in these other behaviours that aren't just about aggression. So inappropriate sexual behaviour, perseveration and repetitive behaviour, wandering, absconding, inappropriate social behaviour and adynamia. And so it's kind of capturing all of those, well not all of them, but you know, the main symptoms that I referred to in the slide before. And I suppose the characteristic things that we're seeing here, that in that prevalence study, inappropriate social behaviour leads the field. Closely followed by verbal aggression in 27%. Then we have adynamia and lack of initiation in 1/4 of the sample. So these would be the big 3 areas that we need to look at clinically. Now, if we're thinking about, well, you know, I've talked about the neuropathological possibilities that might be accounting for our disturbances of control and disturbances of drive, but we really don't want to be constrained by a neuropathological model. And in this area, we've got to think about lots of other factors. So there's a whole lot of pre-injury factors, we might consider them, like people who had premorbid aggression before they had their injury, or mental health problems. They might have had forensic issues, you know, run-ins with the law. Of course, if they're male, that's right up there. Low socioeconomic status, education. If we look at injury-related factors, we can see those ventromedial and orbital frontal lesions that I've talked about before, and we've also looked at the evidence for injury severity. And I think a recurrent theme of this conference has been that although we are all talking in little modules about cognition and emotion and behaviour, we can't, when we have our patient, think in those little silos. So we have to consider the post-injury cognitive deficits that the person may have, particularly in executive and memory function, comorbid issues with anxiety and depression, post-trauma drug and alcohol abuse, the time post-trauma. And I've put down here high support needs and low psychosocial participation and community integration, because Graham Simpson, my colleague in Australia, has done a predictor study, and those two factors were high predictors of behaviour disorder. In association with pre-morbid mental health problems and injury severity to some extent. But various studies that we read in the literature, if we're looking at predictors of behaviour, behaviour disorder, this is the range of variables that people have looked at. But I still think that there's more work that can be done in that area. Okay, the other thing that I would say is that in this area also, we're looking at overlapping symptomatology. So our differential diagnosis is really important. We must think that just because we see a patient who might be aggressive, we don't have a model where for problem Y we automatically apply intervention X. It is not as simple as that, unfortunately. Unfortunately, we've got to take our time to work out, is the reason that somebody is disruptive in therapy because perhaps she does suffer from those impaired regulation of behavioural controls that we've talked about on the earlier slide? And I've seen all of these patients that perhaps they're in pain, perhaps they're fearful of falling, perhaps they're demoralised, they may not like the therapists. And then we have the old chestnut that therapists and doctors not infrequently have said to me in the past, well, she was like that anyway, so let's just get on with things. And there might be other areas. We also have to think about those disorders of drive. Why are they happening? Is the reason that this man sits around all day doing nothing perhaps because he suffers from an organically mediated inertia or apathy? But maybe he's depressed. Maybe he has fatigue. And we've got another old chestnut. He was always like that anyway, so let's just, perhaps discharge him because certainly falls in the too hard basket, and there may be other reasons. Now I'm going to change tack a little now and talk about, in more detail, about what we need to do in the preliminary stages before we start applying the intervention. We need to make sure we know what we're looking at. And this would be a functional behavioural analysis. This is a problem-solving process to determine the reason that a particular behaviour is occurring. So in the previous slide, I had a whole lot of hypotheses in my head that might be accounting for that disruptive behaviour or that lack of activity. So the knowledge that's gained from a functional behavioural analysis is going to help us select the right intervention that's best suited to address the problem. So we have three components. The first one is direct observation. So we've got to get out of our offices, we neuropsychologists, and we've got to go down there to the dining room where they're having their meals, or the bathroom if they're having their showers, or the therapy areas, and we need to look. And we need to take careful account of what's happening just before those disruptive behaviours occur and what's happening just after those disruptive behaviours occur. So this direct observation allows, we heard yesterday this word, the target behaviour, and this is what we're going to be focusing on very much today in this talk. It allows us to specify that target behaviour. Because it's not enough, if I'm going to have a successful treatment, to say, oh well, we've got an aggressive patient here. What I need to do is, as Wood says, I've got to operationally specify what's meant by aggression. So he's got a whole series of questions. I have to ask, is it verbal or is it physical? Is it directed at staff, other patients, objects? Is it isolated or is it frequent? How long does it last? How severe is it? And sometimes, those behavioural observations are very time-consuming. Alderman and colleagues would perhaps sometimes do time sampling, and that's a way that you can cut down without having to observe in detail for very long hours. I'm just thinking here of Professor Wilson's work when she was developing the WHIM, and what they did was to videotape patients' behaviours that they could then look at afterwards to be seeing what was emerging at what point of time, and that's another possibility that could occur. So this is where I'm going to come back to the overt it's the overt aggression scale modified for neurorehabilitation. So it's not the OBS-MNR, it's the OAS. We're just talking about aggression here, not behaviours in general. So scrub that out of your notes. And this scale has 4 items. So we're talking about verbal aggression, physical aggression against the self, against others, against objects. And each item contains 4 levels. So if we take verbal aggression, for example, the least level for that is that he may shout angrily. That's a non-directed shouting. Right through to the 4th, the highest level is that he makes clear threats to staff, for example. Now, the reason that this, and this is the really innovative thing that Alderman and colleagues have done, is to adapt it so that we can look at these antecedents and the consequences of behaviours. So they've kind of used their detailed clinical knowledge. They've come up with 18 antecedents. So this is the behaviour that was happening just before we've got the disruptive behaviour. So the man's thrown the chair, and we have to think, perhaps was another patient screaming in the background, so it's got nothing to do with anything. Perhaps there was a direct verbal prompt from the staff to comply with therapy. Perhaps the patient who made a request was explicitly denied by staff. So you write down, they've got, it's kind of like a checklist that you can easily just document what was the common antecedent that occurred before that challenging behaviour. And then afterwards they've got 14 consequences, or interventions they call them. So the person's thrown the chair, and what was the consequence of that? Was that aggression perhaps ignored by the staff? Or did a staff member actually go and talk to the patient, say, don't do that again? Or did they have to rush in and immediately give sedative medications by injection to the patient? So having this information and about a whole lot of behaviour incidents will make it very helpful to be doing that first step of a functional behaviour analysis, the observation. So that tells us the facts, what is happening. The next thing is that we have informant methods. So we interview people, the staff, the other relatives, the patient, and we have questionnaires. And this is going to be presenting us with a whole lot of hypotheses about what might be happening to be associated with that behaviour occurring. And then the final thing that is not done very much at all in the neurorehabilitation field, but it's done a lot in special education, is a formal functional analysis. Now, this is a very interesting concept because it takes the form of mini experiments, if you like. And what happens is that those antecedents and consequences are manipulated in order to understand their effects. And this methodology will allow us to predict the behaviour that's going to occur, why it occurs, and it will also inform us about the type of intervention that might be useful. So I'm going to give an example now. This wonderful paper by Dixon in 2004 gives a very nice example of a formal functional analysis. So we have Eddie, who's aged 61, and he suffered a traumatic brain injury. And the target behaviour that was looked at for treatment was these verbal outbursts, consisting of profanities and threats to staff. And this occurred during his daily physical therapy sessions. So what they did was that they identified 4 conditions: attention, demand, alone, and control. And they were examined in a little 10-minute interval, so not very long, each day over 12 sessions. So in the attention condition, the therapist would respond to the target behaviour, the profanity, with a verbal comment within 2 to 3 seconds saying something like, "You should not say things like that." Okay? In the demand condition, the therapist would provide a prompt about engaging in physical therapy. In the alone condition, he was placed in a room by himself and he was observed. And in the control condition, he was allowed to sit in the, whatever, recreation area with magazines, and the therapist would deliver non-contingent attention every 30 seconds and provided no consequences for the target behaviour. So in this little mini experiment, here's the results. Now let me walk you through this. The attention condition are these red diamonds, and they're the 4 conditions. So in session 1 we do attention, session 5, session 9. In the alone condition we've got the green squares, session 2, session 6, session 10, and there. In the demand condition we've got the black diamonds, session 3, session 7, session 11. And in the control condition we've got the purple circles, session 4, 8 and 12. I hope it's as clear to you as it is to me what's happening here. Yeah, we've got the answer. The data clearly show that the target behaviour of these profanities was being maintained from escape by the prompts, which is the black triangles to engage in physical therapy that were provided by the therapist. Because you see here we've got the frequency of behaviour, and it's ranging from, let's say, 13 up to, let's say, 18. Whereas these other conditions are all less than 5. So it's a very clear formal functional analysis there. And so the therapy that Dixon and colleagues did consisted of a differential reinforcement of alternative behaviour. So they would train him to be saying, if you need to take a break, please ask appropriately. So they're shaping this kind of very pro-social behaviour. And each response was followed by 30 seconds of termination of prompts. If he did it properly, they would not make any demands on him. But inappropriate responses were ineffective in terminating the exercise, so those demands kept going. And in that way, I haven't got the graphed results, but they were very quickly able to extinguish that behaviour. So that's a formal functional analysis, and that would that's kind of best practice about what we would be doing before we set up an intervention. Okay. You'll know that we're very big in my research team in looking at, what we do with our clients. We want to have the best evidence for it. So we need to know what the evidence is for the range of behaviours. And the best way, of course, to do that is to be looking at systematic reviews. And here, I mentioned yesterday about PsychBite. I've taken systematic reviews from PsychBite. Now, Ilva-Sarkar in 2007 looked at impulse control after TBI, so very specific systematic review. He was looking at both adults and children. There were 65 studies and only 2 randomised control trials, one of which, I must say, was done by my student, Jessica Med, and the other one was for children. So that's such a poverty of data. When I read Ilva-Sarkar's review, I was shocked, because I thought that, with all the literature that we have, yesterday I showed you on PsychBite, we have got something like 650 interventions for behaviour after acquired brain injury. I thought that we would have a much stronger level of evidence. But he said that if you're going to do specific interventions like anger management, it is only a practice option, looking at contingency management procedures and positive behaviour interventions and supports, simply because we don't have enough rigorous research there. But if you're looking more general, he I think he's fudging a bit here to say it's a practice guideline, but I think he was so concerned about, these behavioural treatments for behaviour disorders being at this low level of practice option. One of my PhD students, Amanda Lane Brown, has done her PhD looking at apathy after acquired brain impairment. And in 2009, we published a study in a systematic review in neuropsychological rehabilitation, where we looked at 28 studies, and we were looking at dementia as well as stroke and TBI. There were 4 studies in TBI, 1 RCT. This is for treatments for apathy. We concluded there is some evidence, but there was not even sufficient evidence to make a practice recommendation. That evidence came from our single case experimental designs for external compensation procedures. And this is where I think the rules have got to change about systematic reviews, because we are so hung up that single case experimental designs don't make it. The Cochrane database of systematic reviews will not include them. Michael was talking yesterday about randomised single case experimental designs being level 1 evidence, so maybe things are going to change. Catalani in 2010, he looked at a broader range of disorders, internalising. We can read here those disorders of drive, externalising, we can read disorders of control, as well as psychosocial kind of disorders like community reintegration. So it didn't really hang together very well. But he's just looking at stroke and traumatic brain injury, identified 63 studies, 5 RCTs. Again, his recommendation is only at the practice option level. And he's saying there's insufficient evidence for the internalising disorders of drive. In 2011, the final one, Bolin, she has looked more broadly at executive functions in her systematic review, but one component of it did look at impulse control. After stroke and TBI, there were 12 studies. The single RCT was again my student, Jessica Meds, on anger management. So she's saying on the basis of that, there is some evidence that treatments to increase self-monitoring and self-inhibition in social situations occurs. When we have such problematic levels of evidence here to guide clinical practice, Guyot and colleagues, who are the doyens of single case experimental designs, N of 1 trials from McMaster University, say that we really should be doing a single case experimental design. It should be at that level, because that is the way that we can determine for our patient, has that therapy worked or not. Just going back to Ilvasaka's review then, because I'm just going to, just give you a brief flavour of, just checking the time here, yes, of the kinds of interventions that there are, and this is for both challenging behaviours and the external and the internal disturbances. Contingency management. So there's a whole group of operant procedures that address the consequences of behaviour: verbal praise, token economies, time out, response cost. And one of the difficulties with that is that we're not actually skill building in a way that's generalisable. But certainly we can address those target behaviours and either decrease or increase them according to what we want. The second group of interventions he's talking about are positive behaviour supports, and here we're looking at the antecedents of behaviours. And it's very much focused on techniques that are going to result in skill acquisition. And if we have that, we might be able to prevent the disorders happening in the first place. And the third level that he looks about is cognitive behaviour therapies and techniques such as education, cognitive restructuring, self-monitoring and self-talk. Now, sometimes, it's going to depend on the level of disability of our patient as to which might be more appropriate as well. So I myself would never dream of doing a cognitive behaviour therapy with somebody who's got major memory problems and executive disorders. It might be, and who also has challenging behaviours. It might be better to be looking at contingency management or positive behaviour supports for such a person. So here's some examples of contingency management, NIGHT. They looked at the differential reinforcement of low rates of responding. What they're looking at in their case MA is a person who was making these provocative verbal comments, and so they're trying to reinforce that if he does less than a certain number of these provocative comments, he will get his reinforcer, whatever that happens to be. Alderman, he's looking at an example. He's published a lot in the literature about a lot of different interventions. His work is very good, and it's, I recommend that you follow that if you're wanting to know more about this area. One of the perhaps more controversial interventions that he looked at is satiation through negative practice. And in his case, JA, this man shouted a lot. And what you're doing there with these kinds of procedures would be, in fact, when he shouts, you encourage him, when he stops, to shout for another 2 or 3 minutes. And, it's a kind of a positive punishment procedure. It is effective, but it does certainly have ethical concerns. And I think we would all agree that if you can be doing something that's going to be less intrusive, that is more positive, that will be advantageous. My view also is that, many of our clients, they don't like the way they are. They've found themselves in an aversive situation, and I think I gave the example yesterday of that young girl who, my response was to get her out of the unit and deal with her depression rather than, kind of trying to ameliorate the behaviour at that point in time. Now, Zenkius, you're going to look at that 1989 and think, what am I doing here? His work is marvellous. So he comes from a group in the United States, and I don't hear anything from him anymore, but in the 1980s and 1990s, he's got a wealth of single case experimental designs that have all sorts of different kinds of interventions. Here, one of them is behavioural contracting. So, you earn points, and if you earn enough points, then you can have your preferred activities. And he did this in a couple of cases to increase their attendance at therapy. Now, Knight, who comes from Alderman's group, have looked at a compare and contrast about 3 different types of interventions. This differential reinforcement of low rates of responding, response cost. Now, this is something where you might be given a number of tokens, for example, at the beginning of the day, and you've got to maintain them. And if you engage in any of those target behaviours, tokens are taken away from you. And then self-monitoring training. So, they're saying that, so the strategy that is used will be positive reinforcement. The response cost, negative punishment, we're not so interested when we can be looking at positive reinforcement. We all agree. Again, response cost, like that satiation through negative practice, it's got some ethical issues there. And, you're taking things away from people. DRL and self-monitoring training, they're less intrusive, and they also build skills approach. And we want our patients to go away not just having the absence of the undesirable behaviour, but actually skills that they can carry through later on. Whereas response cost, that can be seen as degrading. Oh, you did that problem there, give me a token, The thing is, though, that treatment gains, the literature suggests, are much more rapid with response cost than they are with self-monitoring training. The good thing about self-monitoring training that we don't see in the other 2 areas is that treatment gains may generalise to new environments. And of course, that's a crucial thing that we want to be doing when we're looking at our behaviour interventions. So there's pros and cons about all of the areas, but looking at the literature, self-monitoring training, if the person has, kind of got the cognitive skills to support that, or the DRL, there's lots of studies of that in the literature. A couple of examples of looking at antecedent controls. So this is where we're trying to get in there in the first place so that we can prevent the behaviour. Weslowski, and he comes from Zenkius's group, so he's also in that group of people in the 1990s who have done such marvellous work. They developed the concept, and a lot of these things, that's common sense. Mini breaks. So they were in a vocational rehabilitation setting, and what they did was to give their patients who were taking these unauthorised breaks, they'd just walk out of the therapy area, every 10 minutes, every hour they would get a 10-minute break. And then they were able over the course of time to extend that. Feeney and his colleague who's now passed away, Mark Ilvasaker, have also done excellent work in looking at these antecedent controls. And they do wonderful things like they have these prepared scripts that they train their patients and sometimes the staff also to be saying. So the scripts might be, I need a break, or this is going to be hard for me. And by having these kind of scripts, they were able to reduce challenging behaviours. In some cases, these were adolescents in a school situation who would be pushing and hitting and threatening. So very effective. So there's no lack of interventions, is the message that I'm wanting to give here, to be looking at our challenging behaviours. I've talked about anger management training. Again, this was published again in Neuropsychological Rehabilitation, our flagship journal, in the year 2000. There is still to be a second RCT reported. Tessa Hart has done a case series, but of course a case series does not have controls, and so we can't really make cause-effect relationships that we can with a randomised control trial. Now this was small, 16 patients, so we had eight in each group. And what we looked at here was, it was a manual based, and it's based on Novaco's work. So it's based on work that comes from the general clinical population who don't have brain impairment. And so we need to adapt any of those treatments that are used with those kind of clinical populations without brain impairment. We need to adapt these in our work here. But going around the posters, as I've done over the past couple of days, I've seen lovely evidence from your teams here where, you certainly do that in the course of your clinical work, so that's really good to see. But this program, it starts off with psychoeducation. Professor Wilson's already talked about the importance of understanding brain injury and the causes of anger in this case. We present a model of anger. And then a very important stage is increasing awareness of anger. So the ways that we would do that is by getting people to do little rating scales of when they have an anger outburst. How angry was that? And indeed in our follow-up sessions they say that that's one of the most helpful things to them is to have these little rating scales, so it's a little bit like a thermometer, and that they can start to be monitoring their level of anger and distress. And then the fourth component of that kind of program will be training in strategies to overcome anger. So relaxation, if people are getting very het up, self-talk, cognitive challenging, assertiveness, distraction, time out. And in a sense, people can have these, they've got a menu of strategies and they can be choosing whatever is best in a particular situation. The treatment here was 5 to 8 hours, very brief, but it's intensive. It was individual sessions over 5 to 8 weeks, so it was an hour a week. Now these were people who, unlike the kind of cases that we have been seeing over the course of the past 3 days, they were able to be involved in this cognitive behaviour treatment. And the results were that the treated group improved significantly more on the STAXI, which is an anger questionnaire, than the non-treated group. So nice evidence that this intervention indeed works with this kind of clinical group. Unfortunately, there was no transfer to mood or self-esteem. And when I'm reading the literature, I often see these kind of comments. We often build in these additional measures to see, will there be transfer effects? I don't necessarily think that an anger management program should necessarily improve self-esteem. I would be hoping a self-esteem program would be improving self-esteem. So I'm never terribly critical of studies when we don't see those generalisation issues. To me, that doesn't detract from the quality of the study. What I'm interested in is what's that primary outcome variable? It's anger. Did the anger improve? The other issues are very nice to observe, but they're not fundamental to answering the question. And that's just a graph of the results. Now, let's turn and look at apathy. So the converse of our disturbances of drive and control. And here we don't have, there's no RCT. Well, there is an RCT that my student identified. Some kind of wacko treatment it was. I've forgotten what it was. It was irrelevant. The people did not even do between group differences. They just looked at within group differences, so it doesn't even tell us whether the therapy works. But what we have is very rich literature of single case experimental designs. Now Burke, who's again a colleague of Zinkius, he looked at Jack. And in fact, this is a nice example, isn't it, of, what we're going to be looking at here is Jack's problems with initiation. That's in these disorders of drive. He can't initiate, he has this apathy. But look at what else he's got. He's got problems with concentration and memory and monitoring and egocentricity, they say, this comes from their paper, social judgment, insight. Anyway, the setting is, a lot of these people also, they do it in context, which is very nice to see. So it's a local restaurant in the kitchen and pantry areas. And what they're targeting is the number of cues that he needs. Okay, Jack, now you need to fill the pastry cases with the jam. You know what it's like with patients who do not have that capacity. They say to me, my get up and go has got up and gone. They need that prompt and structure the whole time. So that was the target behaviour. They were wanting to reduce that. And he was provided with a simple checklist of 9 daily tasks that for completion. And he used the same tasks, the same order. On day one, he's provided with a rationale for the treatment. This simple treatment. He was given a demonstration, modelling of how to check off the checklist each time he did the various tasks, and how he had to look for the next task. And on the next Monday, he was provided with a new checklist. And look at that. You would think I made these data up. In our baseline, he's requiring 3 or 4 cues. So this is the baseline before we start the intervention, and when and as soon as we introduce the intervention, perfect. When we take the checklist away, now we might think that's an external aid if we're thinking of Michael's talk yesterday, and there was a very interesting question that came from the audience about this very thing. What if the behaviour doesn't revert back to baseline? And in a sense here, we don't really have a very good demonstration that it was the checklist and nothing else that worked. But I think what's happened here, he has internalised this strategy. He's got his own checklist in his head now that has become a strategy. It's not just an aid, and in a sense we can't take it away. So we've got this blip here. We don't worry about that blip because, we've solved the problem. External cues as a treatment for apathy. Now here we've got a study from John Evans from Professor Wilson's group, and what they've got is a single case design. This is up here, a 50-year-old woman, I think. Right, so there she's 7 years post-stroke, and on her CT scan we've got all sorts of ischemic changes there in the frontal lobes. And again, we're seeing that she's not only got this problem of the inertia where she's requiring prompt, but she is distractible and she's disorganised and she's got some obsessive compulsive type behaviours. So we're using NeuroPage as a prompt. So NeuroPage is often used for people with amnesic disorders to assist them with their memory, but it's been also used a lot with disorganised behaviour. It's used as a prompt. She's got to take her medications, water her plants and wash her underwear. And they used a very nice reversal design here in the A condition before she's got the NeuroPage, B where she's using NeuroPage, and here we do see, don't we, not a reversal to baseline, but certainly when we take away the NeuroPage, her performances are not as good as when she's got it. And we've got a nice second B phase there, so that clinches it for us. Yes, it's NeuroPage. So I'm just going to, I've talked about PsychBite yesterday because I want the clinicians in this audience to use this resource. It's a wonderful resource, and I'm going to show you how you do it. It's so easy, like in, 5 seconds less, you get the answer. This is the home page. So you click up there on the search button and up pops the search page. And what we have are these drop-down menus. Now, I'm sorry you can't see this, but when you will on your PowerPoints when you get those. But here we've got the treatment group, the neurological group, and we've got about 7 of these groups. So I can just use the drop-down menu to look at traumatic brain injury. And then, like that. Then I go down here to the target area, and I might be interested in behaviour problems. So again, I click on that on the drop-down menu, and we've got, 30 different types of target behaviours. And I can select all sorts of other things. If I just wanted to look at adults, I could do that. If I wanted to select a particular type of intervention, I could do that. If I wanted to look at a particular methodology, I could do that too. But I haven't here. I've just done those two things. And then, having done that, I click on that search button, and up pops all of the trials. So this is the results page. Now you can't see here, but I'm going to tell you that up pops 172 interventions for behaviour disorders after traumatic brain injury. Now, the best thing about this database is that here we've got 172, so it's spread there over something like, whatever that is, 17 pages. And here I'm at page 3, because the first 2 pages are systematic reviews. Because what we do in this database is that we rank order all of the results in terms of method strength. So not by author, not by year of publication, but by method strength. So all the systematic reviews are first, all the RCTs are second, all the but controlled clinical trials are third. And even better is that over here on the left-hand page, for all of the primary studies, we rate their methodology scientific quality. And so we can see here, and they're ranked on the database. So the top, we use the Pedro scale for group studies. We've got 8 out of 10 is the best, so that goes number 1. And so it goes down. And here's the Med and Tate study down there that scored 6 out of 10, and we've got some studies in between. So we've got, kind of like 17 pages worth of that. And so then you can go down and you can look at what might be useful for your particular patient. So this study here that scored 8 out of 10, very good method quality, but it's about children. So I think, I'm more interested in adults. So I wouldn't click on that to have it bring up the source and the abstract. So, in summary, there's vastly more information available for interventions to treat poorly regulated disorders of control than there is to treat deficiency in behaviour, the apathy and the other disorders of drive. And so there's a huge need to increase the knowledge base of the latter. Now, the literature on interventions for challenging behaviours is largely single-case experimental methodology. And in general, when we rate those, because we rate those with, Michael talked yesterday about our risk of bias in N of 1 trial scale, they're good, they've got good scientific quality. Now, although much of the literature is old, and I've already talked about Zenkius's group in the US, I don't think that matters in one sense, because the principles that they've got in those studies, they provide a really valuable heuristic for trialling or adapting various treatment approaches for the patient who might be in the hospital, in the clinic, in the community. And PsychBite provides that wealth of systematic reviews and primary interventions for the management of challenging behaviours. So we've got a lot of information there. So given that a single case approach is what is accepted in this field, and much of the evidence has been provided by clinicians, so Alderman's a clinician, Zenkius is a clinician, Ilvasaka and Feeney are clinicians. They're not researchers. Well, they are researchers, of course they're researchers, but then they're not like me sitting in the ivory tower of a university. They're in the clinic. And they're designing high quality studies for their patients. The practicing clinician is therefore in an excellent position to conduct and publish work from their clinical practices. Now, yesterday I was talking about the MATE, and we talked about the Robin scale as resources that are there for you to design good quality and publishable SCEDs, and I end my address by urging you to do so. Thank you.